This meeting is being recorded.
C'est bon, prof, vous pouvez commencer.
Okay. It's my pleasure to host this first webinar in the new era of collaboration with WIN Global when we became WIN Medicine. It's a new era of collaboration, and many thanks to all speakers, Karen and Mokoala and Ashven. Many thanks to WIN Communication, WIN Global, and many thanks to all participants and to all incredible women working in nuclear fields. The goal is to raise the voice of women, to promote gender equality, to improve young generation engagement, to promote innovation and advanced nuclear medicine, and continues to improve all nuclear fields. The objectives of WIN Medicine is fighting gender inequality and encouraging students, especially women in the medical sector, to choose nuclear techniques as their specialty. To promote nuclear medicine and highlight the pivotal role of nuclear medicine in the precision medicine and theranostic in the health sector, particularly in low and middle income countries. Attracting the younger generation to the field of nuclear medicine involves a multifaceted approach that highlights the exciting opportunity, advancement, and social impact of the field. Today, WIN Medicine celebrates in partnership with WIN Global the 11th Annual International Day of Women and Girls in Science, which coincides with WIN Medicine 4th anniversary under the theme Women Overlooked in Health and Science. The goal is to honor women to have served in the nuclear and health fields. The moderator of this webinar is Dr. Ashven Seeneevassen, WIN Medicine coordinator and a member of WIN Medicine Young Generation. Ashven Seeneevassen is a pharmacist, doctor in pharmacy, and also radiopharmaceutical specialist with master in radiopharmacy at the University of Rabat, Morocco. I have the privilege to have him as a student. He was an excellent student. Currently, he is senior pharmacist at the Nuclear Medicine Department of the Ministry of Health and Wellness at Jawaharlal Nehru Hospital. He developed expertise of nuclear medicine, radiopharmacy quality control, and regulatory compliance. He represented Mauritius in several international scientific and leadership forums. He participated to World
Prof. Nouzha, can you hear us? I think we lost you here.
There she is.
Yeah.
There you go.
Mais c'est pas ma faute, hein, c'est la connexion.
Yes, thank you very much, Prof. Nouzha, for this brief introduction. I'm very pleased to be here amongst you all to celebrate Win Medicine 4th anniversary under the theme of Women Overlooked in Health and Science. So I'll just introduce Prof. Ben Rais. I think everybody in the field knows her by now. It's been a privilege to be her student for years, and I've learned a lot from her. So it is a great honor to introduce Professor Nouzha Ben Rais, a pioneer of nuclear medicine in Morocco and an internationally respected leader in the field. She is the first Moroccan laureate in nuclear medicine trained in France with advanced qualifications from Paul Sabatier University, Tokyo University, and the University of Maryland. Professor Ben Rais is the founder of nuclear medicine at university level in Morocco. She was a professor at Mohammed V University in Rabat, an IE expert and a strong advocate for South-South cooperation, and a strong women's empowerment advocate in nuclear medicine. She has been supervising over 140 doctoral theses and has authored more than 120 international publications. With that, I invite you to warmly welcome Professor Ben Rais to deliver her talk. Yes, Prof, you can go ahead.
Thank you, Dr. Ashven. And it's a pleasure for me to present women in health, overlooked women under the term women overlooked in health and science. Please move. Ashven. Excuse me. It's the first. Ashven?
This one.
Yes, thank you. Firstly, women represented nearly 70% of the global healthcare workforce, yet they remain underrepresented in senior leadership, research, and technical roles. Despite constituting less than 30% of researchers worldwide, women have been critical in advancing health equity, pioneering vaccines, and deriving innovation in fields like medicine and digital health. Second, please. Like all areas, gender parity is persevered, and it becomes necessary to promote parity in nuclear medicine. Gender parity is one of the targets of WIN Global, and it's also one of the 70 United Sustainable Development Goals. Gender disparity in nuclear medicine is perceived in all developing countries, but remains significant in developed countries where gender inequity persists in scientific research and academia. Substantial gender gap, regardless of the editorial board rank, as published in the European Journal of Nuclear Medicine and Molecular Imaging in June 2021, the phenomenon described as leaky pipeline. And you have three chains. The first one concerns the editor-in-chief, the second one associated editor, and the third editorial board member. And as you see, the women are represented in orange, and there are few women in comparison with men. Next, please. And in the same journal publication, the median 5 years and age index of female and male in hybrid imaging and in radiopharmacy and chemistry, also in physics and in research. As you can see, woman is less represented than man. Next. Key role and impacts. It concerns scientific discovery. Women have always been at the forefront of fundamental discoveries such as Marie Curie, Irene Joliot-Curie, Liz Meitner, and Rosalind Franklin. Public health advocacy. Women are crucial in shaping health policy, managing non-communicable diseases, and acting as community connectors in health systems. Concerning modern innovation, women are leading advancement in AI-driven healthcare, telemedicine, and personalized medicine, ensuring gender-sensitive AI models. And I will present two figures as have historic impact, like Florence Nightingale and Laetitia Manford-Gill. They respectively developed sanitation in medicine practice and the innovation of medical syringe by Laetitia Manford-Gill. Next, please. Women in health and science, challenges and equity, and their representation in leadership, and their funded research and disparity. Despite high workforce participation, women face barrier in reaching top position in academia, research, and policy. Women's health issues, such as cardiovascular disease or reproductive health, have historically been under-researched, leading to diagnostic gaps. Women are often concentrated in lower-level roles with less representation in the private sector compared to men. Next, please. On the 11th February 2026 was celebrated the Day of Women and Girls in Science under the theme From Vision to Impact. Redefining STEM by closing the gender gap focuses on practical, evidence-based solutions for inclusion in science, technology, engineering, and mathematics. Next, please. Other society, women health research demonstrate that women have unique health needs and many diseases and conditions affect women differently than men. Next, please. This society develops empowering the health of women in midlife fact sheet, improve women heart health outcome across the lifespan, and research policy and leadership to close the global women's health gap. Next, please. Tribute to Marie Sklodowska. She born on November 7, 1867. She received the Nobel Prize with her husband in 1905 in physics. The other half was awarded to Henry Becquerel for their research on radiation. They isolated two new elements that were highly radioactive, polonium and radium, in 1911. She won the Nobel Prize in Chemistry. The lone woman to have won two Nobel Prizes. Even with their deteriorating health, the Curies continued their research. Much of today's nuclear science is based on their work. In 1934, her daughter and husband, Frédéric Joliot-Curie, discovered artificial radioactivity. Next, please. I like this citation, the two citations of Marie Curie. Each of us must work for his own improvement and at the same time share a general responsibility for all humanity. Life is not easy for any of us, but what of that? We must have perseverance and above all confidence in ourselves. Next, please. Irene Joliot-Curie is the daughter of Marie Curie. Irene and Frédéric Joliot-Curie discovered in 1934 the artificial radioactivity. They demonstrated that stable element could be made artificially radioactive by bombarding them with alpha particles, significantly impacting medicine and nuclear physics. They were jointly awarded the Nobel Prize in Chemistry for the synthesis of nuclear element, and it's the born of nuclear medicine and medical specialty. Next, please. Lise Meitner. Sorry for the screen because we don't see the top. Lise Meitner is Austrian-born physicist who shared the Enrico Fermi Award in 1966 with the chemists Otto Hahn and Fritz Strassmann for their joint research that led to the discovery of uranium fission. Lise Meitner born in November 7, like Marie Curie, November 7. Otto Hahn and Fritz Strassmann discovered nuclear fission in December 1938 in the process of bombarding uranium nuclei with neutrons. They were unsure about how to interpret this result. Meitner and her nephew Otto Frisch explained how energy was released by neutron bombardment during the fission of the uranium nuclei. Next, please. In 1944, Hahn received the Nobel Prize for Chemistry for discovering nuclear fission. Some have argued that Meitner merited a share of this award. During this time, she was invited to work on the Manhattan Project. Meitner opposed the atomic bomb, however, and she rejected the offer. Next, other figure in the health sector, Rosalind Franklin. Rosalind Franklin was a physical chemist who made pivotal research in the discovery of the structure of DNA, known as the most important discovery in biology. While working at the King's College London in 1951, she discovered two types of DNA called A DNA and B DNA. Next. Her X-ray image of DNA, as shown in the slide, indicated helical structure. Her X-ray image of bDNA taken in 1952 became the best evidence for the structure of DNA. For the discovery of the correct chemical structure of DNA, the Nobel Prize in Physiology Medicine or Medicine 1962 was shared by her colleagues and close researchers James Watson, Francis Crick, and Maurice Wilkins. She had died 4 years earlier in 1958, making her ineligible for the award. Next, please. Other two women, it concerns nurses. Nurses, women overlooked in health. Both women profoundly, Laetitia Manford-Gier and Florence Nightingale, transformed nursing and patient care through practical evidence-based improvement in respectively environmental, hygiene, and medical instrumentation. Florence Nightingale revolutionized healthcare by pioneering sanitation, hygiene, and environmental factors, fresh air, cleanliness in hospitals during the Crimean War, and drastically reducing mortality rates. Laetitia Manford-Gier invented and patented the one-handed medical syringe in 1899, which improved injection safety and remains the foundation for modern single-handed device. Next, please. Florence Nightingale, sanitation and nursing. During the Crimean War, in fact, she found 50 conditions causing high death rates. She implemented cleaning routine, proper laundry for linen and ventilation, reducing mortality from 42% to 22%. Next, please. She established that sanitation, light, warmth, and cleanliness were critical to patient recovery, as detailed in her book, Notes on Nursing. She founded the first secular training school for nurses at St. Thomas Hospital in 1860. Next, please. Laetitia Manford-Geer invented and patented the one-handed medical syringe in 1899, improved injection safety, and remains the founder for modern single-handed devices. Next. Her research improving upon previous model that require two hands, that's allowing for easier self-administration. Her design allowed clinicians to inject patients while keeping one hand free to stabilize them or manage equipment. While often overlooked, her invention directly influenced the design of modern medical syringe used until the introduction of disposal plastic in 1950. Next, please. As published in the prestigious review, The Lancet, about advancing women in medicine and global health, advancing the future consists to increasing the representation of women in leadership and research is critical for producing the best patient care, reducing system bias in health. Effort to improve this includes supporting women-led startups, promoting gender-balanced panel, and fostering careers in disease research. Next, please. In conclusion, the ultimate goal is to achieve gender equality. The mainstreaming of the gender perspective is the process of assessing the impact on men and women of any planned action, including legislation, policy, and program in any sector and at all levels. The concept of diversity incorporated into the gender equality approach means recognizing that women and men are not homogeneous groups. In addressing gender and health issues, differences between women and men with respect to age, socioeconomic status, education, ethnicity, culture, sexual orientation, disability, and geographical location should be taken into account. Please, next. The gender differences in health have caused widespread concerns. Consideration of gender differences is important for the prevention, diagnosis, treatment, and management. The differences are mainly caused by innate gene, hormone, and environmental influences, common factors and common specific risk factors. Awareness of the gender differences will help to have a better prevention. Moreover, gender-related variables remain to be defined and added to current risk assessment in the future studies. Next, please. Future research can focus on how to define and add gender-related indicators to current risk assessment and management strategy to list and to analyze the possible causes associated with the differences in order to highlight the necessity of taking into account gender differences in determination of the health risk profile. Next, please. Thank you for attention and happy birthday again, the 4th birthday of Will Medicine. Thank you for your attention.
Thank you, Prof. Ben Rais, for paying tribute to all these inspiring women in the field of nuclear medicine. And thank you for highlighting also the crucial role of women nursing officers in healthcare. I think that they have undoubtedly shaped the way we practice medicine today. With that, it is my great pleasure to introduce you to another inspiring lady, Professor Karen Jones. Is a professional senior research fellow at the University of Adelaide and collaborates closely with the University of South Australia She also serves as principal medical scientist in the endocrine and metabolic unit at the Royal Adelaide Hospital. She is an internationally recognized expert in nuclear medicine and molecular imaging. Professor Jones has also made significant contributions to PET imaging, quantitative imaging methodologies, and translational research aimed at improving patient care. She is currently the president of the Australian and New Zealand Society of Nuclear Medicine, and she serves as a governing board member of the National Imaging Facility, reflecting her leadership in advancing imaging research and nuclear medicine across Australia and New Zealand. With that, it is my great pleasure to yield the floor to you, Professor Karen Jones. We look forward to hearing your inspiring journey in the field. Thank you.
Thank you, Ashven. I'll just share my slides. Okay, hopefully you can see those now. So the title of my talk is From Gut Feelings to Facts, and I was asked to talk about my success story, and my success story really relates to my journey in nuclear medicine, from being a nuclear medicine technologist to an internationally recognised clinical researcher. And this is a quote by the famous American baseball player and coach Yogi Berra. And he said, "It's tough to make predictions, especially about the future." And certainly that's the case for my career. So this is an overview of my talk for today. I'm going to talk about my early years and what attracted me to nuclear medicine, my research career, and the importance, as Yogi Berra alludes to, of serendipity and chance. And then I'm going to focus a bit on clinical research, which mainly relates to how the stomach empties food, gastric emptying. And then I'll mention briefly about some of the professional societies that I have been involved in and continue to contribute to. So this is a photograph of my Year 12 high school cohort, so the final year of my high school year. And you can see that I'm pictured here just with the red ring. And like many Year 12 students, I really didn't know what I wanted to do when I left school, because I was raised in a culture where my family members hadn't gone to university. My mother didn't even go to high school. So I really didn't know what I wanted to do. And so I spoke to the careers counsellor, Mr. John Pole, and he said to me, "Karen, you really love science and maths, and I think medical radiation would be a good field for you." And I later found out that he had a daughter that was the same age as me, and she was going to be a radiographer. So this is my class of 1990 of medical radiation scientists. And back in those days, radiography, radiation therapy and nuclear medicine was all common in the first year. And I hadn't heard of nuclear medicine. And we were asked at the end of our first year to choose a stream of medical radiation to go into. And all of a sudden, I was exposed to this field of patient care, computing, hematology, and imaging. And I just knew that nuclear medicine was the path that I wanted to take. So after my graduation, I worked at Flinders Medical Centre in South Australia. And so why did I move into research? It was very uncommon for nuclear medicine technologists to do research, but serendipity played a role. And one of my clinical supervisors that had mentored me during my student years had told me about a position that had come up in research in the Department of Medicine, which was linked to the University of Adelaide, and they were looking for someone to do their nuclear medicine experiments. And I thought, this is a great opportunity. And I thought that I would only do research for a couple of years and go back to clinical nuclear medicine. But all of a sudden, I was exposed to this world of research and I just loved it. So I decided that I wanted to do a PhD. But the problem was I only had a diploma and there were no PhD programs for nuclear medicine technologists at that time. But I was working in a really wonderful department of medicine, and they encouraged me to enrol in that department and complete my master's qualifying year. And at the end of that first year, I already had one publication and had finished 2 other projects, and so they upgraded my master's to a PhD. And the wonderful thing about doing a PhD is that I was able to travel overseas to conferences. And so this is a photograph of me in 1994 as a PhD student attending the Society of Nuclear Medicine meeting in Orlando. And that was a great opportunity to meet Professor Bill Phillips, who was a nuclear medicine doctor working in the same field of research as me, looking at gastric emptying and its role on blood glucose in type 2 diabetes. And Bill and I remained in contact over the last 30 years, and it was a great pleasure for me that Bill came to Adelaide to visit my lab and stayed at my house. So here he is having a barbecue, cooking a barbecue with my husband. And during my PhD, it really brought home the importance of complementary expertise. So this is a photograph of my wider research group, and you can see that there's the major strength of our research group is our diversity, ranging from nuclear medicine, dietetics, endocrinology, gastroenterology, and many other fields. So I completed my PhD in 1997 and then graduated in 1998. And I got a job at the University of South Australia, where I was able to introduce the very first honours and master's programs in nuclear medicine, radiation therapy, and medical imaging. So that was a great thrill for me. But like many women, we have career disruptions. So these are my 4. So I was able to balance my research career with raising my family. And if anyone tells you there's such a thing as work-life balance, there isn't really. It's more of a work-life juggle. So this is my family, including my dog and my cat. And I can tell you that raising a family of 4 children, that sometimes it'll be messy. It's frequently exhausting, and you must always expect the unexpected, but it's always fun. Now, my family are much older now. My youngest child, Sam, is 14. So it's not as busy as it was, and it's still a lot of fun. And all 4 of my kids still live at home with me. So now I'm going to move on to my research. And for the last 4 decades, my research focus has really been on the role of the gut and how it's central to blood glucose and blood pressure control in humans. And it was the Roman Emperor Marcus Aurelius who said we need to learn to measure what we value, not value what we can easily measure. And this is particularly important in nuclear medicine. And also most of the information about gastric physiology has come from measurements of gastric emptying, in which nuclear medicine is the gold standard. Now, humans have always been interested in digestion, and the first measure of gastric emptying dates back to the time of the Holy Roman Emperor Frederick II, where he ordered 2 men to be fed a large meal, and then he sent one hunting and ordered the other to rest to determine under which condition digestion is aided. He then had both men killed and disemboweled and looked at their stomachs to see that the stomach of the man who had rested was empty, while that of the man who had been hunting was full. Now, I've been working in research for over 30 years, and I can tell you that ethics committees do not allow this kind of research. Now, fast forward several 100 years later, and this was before we had our nuclear medicine technique. A lot of information about gastric physiology came from exploring patients who had a gastric fistula. So this is Alexis St. Martin. And he was a Canadian fur trader, and he was the victim of an accidental gunshot wound with a musket. Remarkably, he survived that injury, but unfortunately the wound didn't heal over, and he had a large hole in his stomach. His treating physician was Dr. William Beaumont, who was an army doctor. He started his career as a meteorologist before he went into the army, but he became a doctor and he treated Alexis St. Martin. And after Alexis got better, he encouraged him to become his servant. And during that time, he was able to do a number of experiments where he was able to look at how quickly the stomach digested food. But some of these experiments were quite nasty. So he looked at how he could inflict pain on Alexis St. Martin or make him feel angry or sad to see how that impacted on digestion. So fortunately, there has been a lot of technological advances, and we have several methods to assess gastric emptying. And I mentioned that scintigraphy or nuclear medicine is the gold standard technique. And this was developed in the 70s and 80s. And for those of you that don't come from a nuclear medicine background, we can radio label food. The patient or the volunteer eats that food, and the gamma rays are detected by a gamma camera, and we can look at how quickly the stomach empties. So this is the type of camera that I worked with when I first started my research back in the 1990s. So this is a volunteer who has their minced beef patty radio labelled and a glucose drink, and she's sitting with her back against the camera. And this is a photograph of our computer processing room. And it was a very large room that was refrigerated so that the computers didn't overheat. And those sort of cylindrical devices there, they were about the size of a pizza and weighed 4 kilos. They were the floppy disks that stored all of our data. Now, one of the things that I really loved about research was that you're always learning something new, discovering how the stomach works, discovering myths and working out the facts from the gut feelings. So I'm going to go through a couple of the myths that I have dispelled over the years. The first of those is that disordered gastric or stomach emptying occurs infrequently in diabetes, and that upper gastrointestinal symptoms are predictive of gastroparesis or delayed gastric emptying. And this is a seminal paper that was published by Paul Cassander in 1958. And in this study, or in this paper, he noticed that in patients that were insulin-dependent patients with diabetes, that they had increased retention of barium on X-ray, and they had poor control of blood glucose, and that was in the absence of symptoms. And this is an example of an X-ray of one of those types of patients. So this is a patient with type 1 diabetes. This is 6 hours after they've ingested their barium, and you can see that most of it's still in the stomach with only a small amount in the small intestine. And Cassander was the first to coin the phrase gastroparesis diabeticorum, and he thought that it was more overlooked than diagnosed, and that it may influence the satisfactory treatment of diabetes. And so up until this time, we really didn't know the prevalence of disordered gastric emptying in people with diabetes. And this is some data from our group in long-standing type 1 and type 2 diabetes, and using scintigraphy or nuclear medicine. So it was radio-labelled minced beef, that was the solid, and a different isotope to label the liquid. And the red value is the normal range. And in health, there's a wide range of normal gastric emptying between 1 and 4 kilocalories per minute. But what this data shows is that in about 50% of patients with long-standing poorly controlled diabetes, they have delayed gastric emptying, and this is true in about 30% of patients for liquids. And there are a couple of patients who have more rapid gastric emptying. Now, it was thought that there was a strong correlation between a delay in gastric emptying and symptoms, and we found that that isn't the case. You can have patients who have normal gastric emptying, but they suffer from a number of symptoms, and on the converse, that you can have patients that have delayed gastric, they can have normal gastric emptying and no symptoms, or delayed gastric emptying, a lot of symptoms. So the facts are that gastric emptying is delayed quite frequently, 30 to 50% in patients with type 1 and type 2 diabetes, and that the relationship between symptoms and that delay in gastric emptying is weak. So the next myth is that delayed gastric emptying is the result of irreversible autonomic nerve dysfunction, which is quite common in people with diabetes, and that the blood glucose concentration doesn't affect gastric emptying. So it was historically believed that that this delay was due to autonomic nerve dysfunction, and while there is a correlation, it is relatively weak, suggesting that there were other factors affecting the rate of gastric emptying. And this is some data from my PhD in the 1990s, where we clamped the blood glucose concentration in normal subjects to either hyperglycemia, mimicking a patient with poorly controlled diabetes, and compared that to clamping the blood glucose at the normal level. And what you can see is that the rate of gastric emptying is much slower in those who have high blood sugar levels. Conversely, this is some data where I'm the senior author looking at low blood sugar levels, so hypoglycemia compared to normal blood glucose. And when patients have low blood sugar levels, their stomach emptying is more rapid. And this is thought to be a counter-regulatory mechanism to increase gastric emptying and absorption to bring that blood glucose level back to normal. So the facts: delayed gastric emptying is only weakly related to autonomic nerve dysfunction. It's slowed by high blood glucose and accelerated by low blood glucose. And the measurement of blood glucose during gastric emptying studies, it was our data that led to the introduction of measurement of blood glucose in nuclear medicine international guidelines. So I was quite proud of that work from my PhD. The next myth is that gastric emptying is not an important determinant of postprandial glycemia. And there are many reasons why blood glucose rises after a meal, but gastric emptying was not thought to be all that important. But in our studies by our group, we've shown that both in healthy subjects and in people with type 2 diabetes, there's a very strong correlation between the rate at which the stomach empties and the rise in blood sugar levels after a meal. So the more rapid the gastric emptying, the higher the blood glucose. And this has implications for the treatment and management of diabetes. So to give you an example, if we slow gastric emptying using the drug morphine, so in the blue, gastric emptying of solids and liquids is slower than the placebo in yellow, you get a lower rise in the blood glucose concentration, whereas if you have more rapid stomach emptying, for example, after having erythromycin, which is an antibiotic that accelerates gastric emptying, you get this increased blood glucose response. So gastric emptying accounts for about 30 to 40% of the variance in that initial rise in blood glucose in response to carbohydrate in both healthy people and in diabetes. And these excursions can be modulated by modulating gastric emptying. So they can be attenuated when gastric emptying slowed. Now, I'm sure that many of you are familiar with the wonder drug Ozempic. Now, Ozempic is a GLP-1 receptor agonist. So what is GLP-1? It's glucagon-like peptide 1, and it's an incretin hormone that's released after eating, and it's important in controlling blood glucose levels because it helps in the production of insulin. Now, in humans, it has a very short half-life of only 2 to 3 minutes, so it can't be used to treat diabetes. However, let me introduce you to the Gila monster. So the Gila monster is a venomous lizard that's found near Mexico in the southwest of the United States. And it was found that it has Xendin-4 in its venom, and it's very similar to GLP-1. It's got a 53% homology. However, it remains active for hours. And this led to the development of the first GLP-1 receptor agonist, and the first one was the short-acting agonist exenatide in 2005. Now, GLP-1 receptor agonists can be divided into short-acting and long-acting drugs based on their plasma half-life. And over the last 20 years, there's been a rapid development of these drugs, so much so that it's big business. In 2024, the global spend was 53.5 billion US dollars. To put that into perspective, for those of you that work in nuclear medicine, in 2024, the total global spend on all radiopharmaceuticals, both for diagnosis and therapeutics, theranostics, was $10 billion. So this is really big money. So the myth was that long-acting GLP-1 receptor agonists don't slow gastric emptying. This is some gastric emptying data in the short-acting drug, the first GLP-1 receptor agonist, exenatide, given twice daily. And you can see that compared to placebo in the blue, there are two doses here, 5 microgram and 10 microgram, but they markedly slow gastric emptying, but it's quite variable between patients. And this has been shown to be the major mechanism for glucose lowering. Going back to the data where I showed you, where we were the first to demonstrate the relationship between the rise in blood glucose and gastric emptying. So it's exactly that mechanism. However, there is much less data relating to long-acting drugs, long-acting GLP-1 receptor agonists. There are only about 6 papers published using gold standard methodology. This is one of my papers with the long-acting drug exenatide once weekly, showing that gastric emptying of both solids and liquids are delayed with this medication. Now, given that both short and long-acting drugs slow gastric emptying, it isn't surprising that we started to see incidences of medication-induced delayed gastric emptyings. And this was the first case report of 2 patients who presented at endoscopy, and they had fasted overnight, but they were found to have food in their stomach. And this is an example of one of those patients. This is a type 2 patient on semaglutide. They had fasted overnight. They presented at endoscopy. The pylorus was completely open and unobstructed, and yet there was food in the stomach. So the facts are that short-acting GLP-1 slow gastric emptying markedly but variably, and long-acting drugs such as Ozempic and Wegovy also slow gastric emptying. But much more information about the effects on gastric emptying are required using our gold standard techniques so that we can establish good guidelines for fasting, particularly prior to endoscopy and surgery because of the risk of aspiration. So, of course, research is not done by one person. It takes a village. And this is my research team of chief investigators, postdocs. We have research staff and, of course, my research students. And a highlight of my career has really been the mentorship and training and support of students. Many of my students have come from a nuclear medicine background, and it's wonderful to see them succeed. And many of them have gone on to win their prize for presenting their research at our annual scientific meetings. And I wanted to just speak briefly about my professional society, the Australian and New Zealand Society of Nuclear Medicine. I first joined over 30 years ago as a student member, and I've served on many committees within my society, and it's been a true privilege. I'm currently the president, but one of the highlights was being selected as the highlight countries for Australia and New Zealand last year at the SNMMI meeting to really showcase what we're doing in our region in nuclear medicine. Finally, it's my links to the ANZ SNM that really led me to form a collaboration with Women in Nuclear Win Australia, and we have a regular webinar series for International Women's Day. We've done that now for many years, and I've also taken part in other initiatives through Win Australia, and that introduced me to Win Global. So it's been wonderful to be involved in so many wonderful organisations and work with extraordinary women. So I'd like to leave it there, but I wanted to leave you with this quote, this Irish proverb of strong women: may we know them, may we be them, and may we raise them. Thank you.
Thank you, Prof. Jones. I think that that last citation really strikes. Thank you for sharing your professional journey, and thank you for the research that you've been doing for all these years.
Thank you.
Without any further delay, it is my pleasure to introduce Professor Kgomotso Mokoala, Associate Professor and Head of Clinical Unit in the Department of Nuclear Medicine at the University of Pretoria and Steve Biko Academic Hospital. She recently served as President of the South African Society of Nuclear Medicine and is a council member of the Colleges of Nuclear Physicians. Professor Mokoala obtained her PhD from the University of Pretoria and has authored over 50 peer-reviewed publications, contributed to book chapters with major publishers, and presented widely at national and international meetings. Her research focuses on theranostic applications in oncology and translational nuclear medicine aimed at improving patient care. She has been recognized as C2NRF rated researcher and is a recipient of Chris Johnson Young Researcher Award 2023 at SASNM, as well as UP Young Researcher Award. Prof. Mokoala, among all of her duties, also serves on the MEd and postgraduate committees at UP. I was privileged to be trained at her institutions for 3 months last year, and they are doing a wonderful job over there. Thank you for that, Prof. Mokoala. And I yield the floor to you. The floor is all yours for your presentation. Thank you.
Thank you, Dr. Seeneevassen. And thank you to Prof. Rais for giving me this opportunity to be her deputy. And thank you to everyone for joining. It's a Friday afternoon, so I will try not to take up any more of your time so that we can go and enjoy our weekend. We all know the topic that was given to us about being women overlooked in health and science. Sorry, I'm trying to move. Yes. Okay, so why overlooked still matters in 2026? I think the issue here is more of a systemic problem. And it's because women still contribute quite significantly to healthcare delivery and research. If we look at the workforce, data has demonstrated that women make up a large portion of the workforce. So they do contribute to that. However, they are still underrepresented when it comes to senior academic leadership. They are less visible in high impact science. And unfortunately, whether we like it or not, we carry dual, we have to do some sort of multitasking between clinical duties as well as caregiving duties. And another spanner in the works comes in the fields that we are in. So nuclear medicine and radiation sciences are further increasing because I'm sure in most divisions, departments across the globe, the leadership roles have historically been males, and there's limited mentorship pipelines from females or for females. And I think while we know that this barrier is there, it is invisible, but we know that it's there. And I think the key is to train and practice, it's to try and find a balance, between clinical service, research productivity, as well as teaching responsibilities that we all carry. And oftentimes women find themselves being the only woman in the room. And I think this needs to change. And we are expected to prove our credibility, whereas the male, it's not so much that they have to prove themselves. When it comes to the females, for you to be considered for any position, a leadership position, or whether it's in the clinical setting, it's in academia, it's in science, in editorial boards, you really, really have to prove yourself. You have to work 10 times or 100 times more than the male counterparts. Now, my story, personal story, I didn't go as deep and detailed as Karen did, but nonetheless, I started medical school from 2002 to 2007. 2011 to 2015, I started my registrar program in specializing in nuclear medicine. And in 2011, when I started my register program, I found out I was pregnant with my son. So obviously that delayed the group that I started with. My colleagues that I started with obviously proceeded while I had to obviously take some time out for maternity leave, and then finish the program in 2015. 2016, after I finished my program, I then gave birth to my daughter. And then in 2019, I started my PhD program and finished in graduated in 2022. Yes, so I think for me personally, I don't know. I think success is a journey. I'm not there yet. I'm not there yet, but I think one of the key things when it came to research for me personally, I wanted to engage in research in research that is going to have an impact. And I think one of the key areas, if we look now at publications across the globe, there's prostate. It's prostate galore. And when it comes to female malignancies, there is underrepresentation in terms of the research that's going into that space. And yet lots of women are dying from female-related malignancies and oncology cases. So that has been my area of focus. And I have also been fortunate to work in an institution that does a lot of radionuclide therapies. And I was fortunate to participate in a radionuclide application, epidermal application of rhenium-188 for non-melanoma skin cancers, as well as for keloid lesions. And we actually wrote one of the first publications on the use of this technology in keloid patients. Again, I think the key in terms of research is always doing contextually relevant research. So while the application and the application for the rhenium cream was mainly for non-melanoma skin cancers in our country, and I think in the highly melanated individuals, we have a high population that struggles with keloids. And in terms of the management, there are high rates of relapses from surgery, from the brachytherapies, and from the other various types of therapies that are available to these patients. So this therapy I'm very excited about because it has shown great results. It's unfortunate I didn't put these results here, but nonetheless, I have presented that in various other platforms. Perhaps one day, Prof. Rais will have an opportunity. In terms of supervision, I supervise MMeds and PhD candidates. And I think for me, the key thing when it comes to supervising whether MMeds or PhD candidates is to ensure that the next generation has the ability and the capacity to do research. So it's not just about publications, but that you are teaching the next generation how to do proper research that is ethical as well. So that is, I think, for me, one of the key things. These are just some of the publications that I have authored. It's not an exhaustive list. I think it was just to try and highlight that, the papers that I've written are mainly in gynae malignancies, and then there are those two that speak to the skin therapies that I spoke about. In terms of the leadership roles, I think as Dr. Seeneevassen has introduced, I am NRF rated researcher. I also participate at the institutional level as an MMed committee member, as well as the postgraduate committee. I am the immediate past president of the South African Society of Nuclear Medicine, and I was recently a TWC organizing committee member. And thanks to Prof. Rais for the invite to be her deputy in this Women in Nuclear Global. And I look forward to the term that we're going to serve together and doing amazing things. And I believe in advocating for gender equity, leadership readiness, and representation from the global south. I think I'm just going to share a bit of, it's not even a bit, just to highlight a few of, I feel, key success stories or key areas that I feel I did well as a leader. But again, I think I put the slide up because it's not a one person or an individual thing. It's a team effort. So this was the council that I served with, a very amazing team of mostly females, but we did have three males actually. Let me not. So it was balanced, but I do value each and everyone's contribution. I was fortunate to be the president of the day when South Africa was the highlight country, and I led the team to SNMMI, where we showcased what South Africa has to offer as a nation in terms of the science that we have to bring and in terms of the culture and everything else that South Africa has to offer. And that was also the year that we were celebrating 50 years as a society. And these are just some of the other pictures from that. In terms of the whole woman in nuclear global as a whole, I believe that we need to support low and middle income countries. If you check, and I think I'll demonstrate that in one of the papers that was published in terms of female representation from the radiology field, there was 0 females represented from low and middle income countries. And when it comes to South Africa, again, there was 0 females. So I believe that that's something that we need to focus on. And I think Prof. Ben Rais selecting me to be her deputy, I think, is a step in the right direction. And then we also need to support resource-constrained health systems. Yes, I think in terms of equity, safety, and ethical science, I've highlighted some of those things, especially when it comes to female malignancies, that it is an area that needs a lot of focus that we have neglected as nuclear medicine fraternity or as the global community in terms of the health community. So I think this is the very key slide for me to speak about the hard truths as to why women are still overlooked, even when they're successful. And I think the key thing here is that we have lack or under sponsorship, but we are over-mentored. And what that essentially means is that you've got enough people that can teach you the skills, whether clinical or, I don't know, something as silly as presenting skills or management skills, etc. But we don't have enough people that stand up for us as females behind closed doors, that will advocate for you, put their reputation aside to ensure that you are visible and to ensure that you are promoted in the necessary. Of course, this is not just to promote or to promote anybody who's female, but a deserving candidate. Having a sponsor speaks to someone who will speak for you behind those closed doors and ensure that your name is visible. Again, women are trusted with lots of responsibilities, and I think I've highlighted that we form a large portion of the workforce. So we are trusted with lots of responsibilities. You can I'm trying to think of a good example. It just it just went out of my head. But we don't have the decision-making authority. So we can't sign off on things. We can't sign off on budgets. We can't, so while you take the responsibility of the smooth running and ensuring the workflow goes well, the decision essentially does not stop with you. It does not rest with you, and you don't have that decision making power. And I think we lack leadership pathways that are transparent. So these are some of the articles that I spoke about. This was a podcast that was just speaking to female representation on editorial boards and gender-related publications. This is just a graph that I took that shows the growth of representation of females in editorial boards from 2002 to 2023, and that has shown some growth, but I mean, we're still under 50%. So there is still some work to be done. And then this one, bringing it closer to home. This is nuclear medicine, and it was written by one of our prominent authors, and she's actually an editor of one of the journals, the Clinical and Translational Imaging. So kudos to her. So she wrote this article that speaks to the gender disparities, and I think you can appreciate the red is female, so you can always see there's always that disparity in female versus male in representation across journal boards, editorial board membership. And then this one was speaking to radiology. And again, this is just to highlight that this is not unique to nuclear medicine. It's, again, a systemic problem that spans through all the different medical specialties. So in terms of radiology, this was another paper that found similar findings. And I think where I wanted to highlight this particular paper, so this is a continuation of it, is where they spoke of gender representation by World Bank income group, and the low and middle income countries showed no female editors at all. And the table on the right, we can appreciate, well, I was focusing on South Africa, and again, South Africa, there's zero in terms of female representation. There is one male, but again, maybe I needed to have done a quick sweep of the entire low middle income country, but it speaks and it supports that statement that I made earlier, that we need to support low and middle income countries, because you can see even when it comes to the male, there is still underrepresentation. However, the females, it's even worse. Then this is just in different fields as well. So internal medicine, orthopedic, and general surgery also suffers the same fate in terms of representation of females in these editorial boards. So I think the role of Women in Nuclear Global, which is the platform that we're on, can create platforms for visibility. It can help influence policies, and it can assist in career acceleration of individuals. And I think we need to normalize women being considered leaders of science in the various fields, and being decision makers and role models as well. And I think the call to action that I identified for institutions is that they need to measure equity and not intention. There's always talk about gender equity or equity as a whole, but is it actually there? Is it measurable, or is it just an intention of all institutions or most institutions to have that, but it's not happening? And then it's also to promote women into decision-making roles. Like I highlighted earlier, we have responsibilities, but not authority. So when it comes to decision-making, the women are left out. And then I think for us as women, we need to claim expertise. I think it's always a fine line and a difficult one to navigate this one, where, you know, you need to strike a balance between two. I don't even know how to put it. Being too, maybe for lack of a better word, I'll use grandiose versus, you know, claiming your space. If you're an expert in that field, put yourself out there and ensure that you are seen and you are visible. And then what we need more of is to seek sponsorship. And I highlighted what a sponsor is, as opposed to mentors. I'm not saying we don't need mentors. We need both. So you need mentors, because remember I said mentors help you with developing your skills. They help you with, you know, your emotional intelligence, etc. But the sponsor is that one individual who will ensure when they're sitting in a boardroom somewhere, they will remember that, oh, so-and-so is an expert in this field. Can we call on them to come and, you know, represent this, or to come and participate in this paper, or to come and sit in this board? And then we need to lift others as you rise. And I think that speaks to Karen's last statement that she made, that that saying that she put at the end of her presentation. And then for the next generation, you are not invisible. The system just hasn't caught up yet. But I do hope that we will get there. Sorry. Sorry. Yes, so visibility is power. This is a saying that I want to put there. Visibility is power, representation is responsibility, and leadership is not given, it is built. So I think in terms of what I proposed for us as Women in Nuclear Global is to consider something like developing a global expert registry where we have, people in the different nuclear related fields that we can put on this registry, such that when we have webinars, when we have, I guess, hopefully it starts out small, but eventually it will be a ripple effect where even for congresses, the people can tap into this expert registry to find people to speak or women to speak on different topics that they are experts in. And to create a speaker nomination protocol for conferences and panels. I think this sort of ties in with the global expert registry. And then lastly, to encourage women to have their own platforms. And I think this is one of those platforms, but continue these conversations further in smaller platforms and then on this global scale. I think we need to also identify sponsors amongst females that will then sponsor. we need to identify sponsors that will sponsor the next generation. So we have those sponsors and senior women that will that are in leadership positions that will ensure that the next generation is also brought along, and whatever expertise that you have, that sponsor or those sponsors can then bring your names in the necessary conversations. Again, I spoke of women, but unfortunately, as it stands, the field and those senior positions, if I can put it as such, they are dominated by males. So we still need the males. I'm not saying we need to shut out the males. So we identify sponsors in both males and females. And one of the sort of key or ways to track that we are in the right direction would be to have some sort of documentation to track that, the sponsors that we have versus the mid-career women or the young generation of females that we have. What has happened, in terms of career growth, in terms of nominations? Has there been anything that has come through from trying to, match these sponsors to individuals? And there's a long list of people that I can acknowledge, but I think I've just summed it up in terms of the hospitals that I've worked at, because I believe that my career in nuclear medicine and who I am in nuclear medicine started from the day I started with my registrarship up until now. I've had several people along the way that have helped groom and shape me in various ways. And Prof and Rais, I look like I'm popping. I'm trying to peep through like I'm a photo bomber there in the photo. But nonetheless, thank you for this opportunity. And I think thank you to the students as well. I think I put it as UP and I put it as generic, but all the students that we've mentored along the way, that we've supervised, and that help us to become better supervisors and individuals at the end of the day. And that's it from me. Thank you.
Thank you very much, Prof. Mokoala. I must say that I've been very lucky to have been trained in your facility, so I know the amount of work that you put in there and the amazing team that you have. So please continue the good work. And as I am a man and I don't feel undermined by what you're doing, rather I feel encouraged and inspired by all of you three. And I think that Win Medicine is very lucky to have all three of you as leaders, and you all are inspiring ladies, and you can inspire the young generations to do better. With that, I think Prof. Ben Rais would like to share the work plan of Wind Medicine for 2026. So I'll leave the floor to you, Prof. Ben Rais, for 5 minutes so that you can share the plan. Let me just share my screen. Yes, up to you. Prof. Nouzha, you're muted. Now it's good.
Where is the slide?
There you go.
Okay, it's a proposed plan for, and you see, the target speaker can be leader and one co-leader or two co-leaders. It depends of you and your time. And organizer, and I host this webinar. I will host another one, and they are proposed in webinar for 2022. In this slide, I put just for oncology, but as suggested by Professor Karen Jones, she proposed me also in other field of nuclear medicine, like perhaps if I remember in neuroendocrinology or on renal scintigraphy or on independent. So, because as I saw, there are only about 25 participants in general, and for 4 years, when I organize and host myself the WinMe webinar, I think it's perhaps it's working time or other, because I think we just put the link four days ago, so it's not enough time for all participants, because Win Medicine members are about 100 with seniors and young generation too. All my students, all as Ashven now, or and perhaps it's the working time. So I think we haven't enough time to discuss about the work plan 2026. And as you are co-leader and as Ashven is the coordinator of Win Medicine, I propose you that I propose, for example, for the end of March, the World Theranostic Day and Soul Earth Day. Perhaps we will do that on 31 March, because it's not depending of me only, it's dependent of other speakers and the WIN community, because since 2026 all webinars and the group experts must give the summary of the webinar 1 month, 2 months before to the WIN communication, give proposed flyer as I sent you in 1 month ago, and the agenda. And we sometimes the WIN communication has a lot of, I think, work. So I just received the response 4 days ago. So I think the timing was very, very short. Like the two co-leaders, Professor Mokoala, Professor Karen Jones, for the next webinar, I can organize it. I can be with you in all webinars, but if you can help me to, as co-leader, to organize yourself some webinars. I can be with you as I just introduce as WinMe leader and let you to organize all the webinars. Donc, for this year, I proposed for the World Theranostic Day in the end of March or probably the beginning of April. And after the neuroendocrine tumors, I think it's advanced nuclear medicine in TAP and the theranostic, prostate cancer in July, breast cancer in October, and thyroid cancer in May, perhaps. But I think minimum is 6 webinars per year. It was just the beginning, the first one, and I will organize also the World Theranostic Day. And I think you give me your opinion about this. And if you want to organize one of these, the others, it will be good also. The second, please. The first one concerns oncology, but we can organize on nuclear cardiology, on neuronephrology, in radiotherapy, because now medicine is not only in nuclear medicine, but also radiotherapy, or others idea if you have. Thank you.
All right. Thank you, Prof. Ben Rais. I think you and your co-leaders will have to discuss about the work plan, and then we'll be very happy to help if need be. So I guess we have time for one question. There are two questions we'll see. So the question is, what strategies would you recommend for re-entering the workforce after a career break? I think Prof. Mokoala, if you want to react to that.
So thank you.
I think she responded to that.
Look, I mean, I think one is being humble enough to acknowledge that you've had a break, and being kind to yourself to acknowledge that you've had a break. So obviously with nuclear medicine and the pace that it's developing, you need to acknowledge that there are going to be gaps. And I think in that, the first or one of the steps would be to identify or have some sort of a support system within the department. And I hope that you are able to identify whether you've got a friend or you've got a few colleagues that you can, speak to that can take you along. That's one. You must be educable or teachable, right? So it means that you must realize that you need to go back to the drawing board, read, catch up on the gaps that you've missed out on, and essentially retrain yourself. I mean, when I went on maternity leave for 4 months, when I came back, just reporting a thyroid scan, I had to remember what is the wording again? What do we, so it's not easy, and it happens. And like I say, now, especially with the huge leaps that nuclear medicine is making. I mean, we blink and there's a new molecule, new tracer, new whatever. So you need to just be in a position to say, I do not know, and be able to ask for information. I think a lot of the time ignorance comes from not being humble enough to ask for help. You need to be able to ask for help because nobody is perfect. Nobody is, 100% knowledgeable. And in areas where you don't know, it's okay to just say, I don't know. I'll go and read on it. And I think that just is a general principle of life that, I personally go by. If I don't know anything, I don't know, and I will go and check on it and I'll go and read on it. That's my personal take. I'm not sure, Karen, if, the kids in between, if you had kids in between your training and your career, and what that looked like for you and what you would advise for the individual who takes a break.
Yes,
Prof.
I
Jones,
mean,
would you like to react in a minute? Yes.
Yeah, thank you. I mean, I was an unusual case because I was primarily a researcher. And so, a lot of my work was reading and writing. So I actually got quite a lot done when I was on my maternity leave, reviewing papers and so on. But I also had a very flexible workplace. So I was able to take my children into my department. So it was a different and slightly unusual and maybe a forward thinking approach. But we have had situations where some of our members within the Australian New Zealand Society of Nuclear Medicine have had their career break, and they might have left the workforce for a substantial period of time, like 4 or 5 years, and then they lose their registration to practice as a technologist, for example. So we've been able to advocate for them to help them retrain and regain their registration. So I think it's an important, you touched on it beautifully there, Mokoala, as getting that support system behind you, whether it's in your local department or within your professional society. You need to reach out for that support, because women will support other women, because many of us have been there and we know what it's like. And we need to build more supports, because women offer so much in the workplace.
Thank you, Prof. Jones and Prof. Mokoala. I think we have 1 minute for one last question. I think Prof. Jones would like to answer that. So with the arrival of AI in nuclear medicine, how do the experts look at the role of nuclear medicine technologists being impacted? If yes, how is it being impacted, and is it going to be significant?
Yeah, I think it's going to be highly significant, but it will never replace a real person. A lot of what nuclear medicine technologists do really relates to patient care and relieving anxiety and getting people up onto scanners. It is going to have a major impact. It's going to improve workflow. It's going to improve processing. But, we're really at the beginning. It's going to rapidly expand, and it's going to require a lot of oversight to ensure that all the correct processes are being taken into account. Probably have big impacts on dosimetry as well. I think we're just really at the beginning, and it's just all happening so fast. Mokoala, did you want to add?
Yes, thank you. I think there's a very beautiful saying that I once read that says that a doctor, well, like I suppose in this setting, even a technologist who is afraid of AI or scared that AI will replace them, you shouldn't actually, no, let me rephrase it. So it says that you should be afraid of the doctor who accepts and welcomes AI than AI on its own. So the person who is likely to replace you is the person who actually adopts and utilizes AI to improve their practice, to improve themselves, rather than the AI as a tool on its own. So I think that's just it. It's not going to replace you, like you rightfully put it. So we need to accept that it's here and just find ways to use it. The only thing is that we need to ensure the ethical practices around AI, and yeah. But that human touch, I mean, I get irritated every time I call the bank, and then there's this automated response, press 1, press 2. I'm like, can I get to the human already? Like, so someone can help me. But and I think in medical practice, like you rightfully put it, that the technologist is at the forefront of the patient care and relieving anxiety. I don't think any AI or any robot can replace that human touch and looking into someone's eyes and having that empathy and that touch, essentially.
And then, if I may add, with your permission, I think that as a student, people should realize, that AI cannot generate new knowledge. For example, when you use ChatGPT, it just browses the internet and gives you information that's already there. So AI won't be innovating anytime soon. It just gives you the same information that is already there on the web. It just does it more efficiently and more quickly. So we just need to know how to use it to our own, need. Okay, with that, I think we should.
Ashvin, it's really funny that you mentioned that, because my 15-year-old at the dinner table tonight, because it is 2 o'clock in the morning here in Australia, at dinner tonight, he said exactly what you said, that, AI doesn't generate new ideas.
Yeah.
So you're absolutely correct.
Yeah. Okay, so it's been wonderful, introducing all three of you inspiring speakers. I would like to thank Prof. Ben Rais for this opportunity. I would also like to thank Win Global for their support in organizing this webinar. And of course, I would like to thank Prof. Mokoala and Prof. Jones also for accepting to participate and share their success stories. I look forward to meeting all of you again. For Prof. Mokoala and Prof. Ben Rais, and I look forward to meeting you in person, maybe at a conference, Prof. Jones. And thank you to all attendees, and see you for the next webinar. Have a nice weekend. Bye-bye.
Bye.
Thank you.
Bye.
Bye.
Thank you.
Bye.